Hello, my name is PJ Arnold, and on behalf of all the investigators, it's my pleasure to present to you the ILLUMINATE-C, a single-arm phase 3 study of Lumasiran in patients with primary hyperoxaluria type 1 and chronic kidney disease 3B to 5, including those on hemodialysis. Primary hyperoxaluria is a rare genetic disorder characterized by excessive hepatic oxalate production due to the deficiency in the hepatic perioxymal enzyme AGT, as shown on the right in red. Excessive oxalate results in recurrent kidney stones, nephrocalcinosis, progressive kidney disease, and ultimately kidney failure. As kidney function declines, oxalate elimination is compromised and plasma oxalate increases, leading to systemic oxalosis and multi-organ damage. Patients progressing to or presenting with kidney failure require intensive hemodialysis and liver or liver kidney transplantation. Lumasiran, an RNAi therapeutic approved by the FDA for the treatment of PH1 to lower urinary ox levels in pediatric and adult patients. Lumasiran decreases hepatic oxalate production by inhibiting the production of the glycolate oxidase enzyme, shown on the right in purple. Here we present the 6-month primary analysis results from the ILLUMINATE-C, a phase 3 study designed to evaluate the efficacy and safety of Lumasiran in patients with primary hyperoxaluria type 1 with impaired kidney function, including those on hemodialysis. Key inclusion criteria included full-term infants to adults, genetically confirmed PH1 diagnosis, an estimated GFR of less than to equal to 45 if greater than 12 months old, or elevated serum creatinine if less than 12 months old. Plasma oxalate greater than equal to 20 micromoles per liter. There were 2 patient cohorts in the study. Cohort A, patients who did not require dialysis or kidney transplantation at study start. Cohort B, patients on hemodialysis. The primary endpoint for cohort A was a % change in plasma oxalate from baseline to month 6, and the primary endpoint for cohort B, % change in pre-dialysis plasma oxalate levels from baseline to month 6. Here are the results. Overall, 21 patients across 13 sites in 10 countries were enrolled in the study, 6 in cohort A, the non-hemodialysis cohort, and 15 in cohort B, those patients requiring hemodialysis. Reduction in plasma oxalate was evident by month 1 and persisted through the end of the 6-month primary analysis period. When looking at the graph, if we focus on cohort A, which is shown in the red dotted line, we see a mean reduction of 33% in plasma oxalate level from baseline to month 6. When looking at cohort B, those patients on hemodialysis shown in the solid blue line, we see a mean reduction of 42% in the change in pre-dialysis plasma oxalate levels from baseline to month 6. When looking at the secondary efficacy endpoints, which is shown on the left side of the slide, when we look at cohort 8, again, those patients not on dialysis, the absolute change in plasma oxalate levels from baseline to month 6 was negative 35.28. When looking at cohort B, the absolute change in plasma oxalate from baseline to month 6 was negative 48.33. When looking at the distribution of the pre and post dialysis plasma oxalate levels in cohort B, we look at the % change in plasma oxalate levels, area under the curve between dialysis sessions from baseline to month 6, we see a reduction of 41%. When focusing over on the right side of the slide at the safety profile, you can see here that 81% of the patients in the study had an adverse event. The AEs occurring in greater than or equal to 10% in either cohort, we see pyrexia, injection site reaction, device-related infections, and diarrhea as the most common. Adverse events leading to discontinuation of study treatment or withdrawal from the study, there were no patients. The majority of adverse events were mild or moderate in severity, no serious or severe adverse events related to Lumasiran, and no deaths of patients who received Lumasiran. So in conclusion, data from the 6-month primary analysis period of the ILLUMINATE-C study showed substantial reduction of plasma oxalate in both cohorts of patients with PH1 and chronic kidney disease stage 3B to 5 with an acceptable safety profile. In patients on hemodialysis, which was in cohort B, substantial reduction in plasma oxalate levels between dialysis sessions were observed from baseline to month 6. Injection site reaction was the most common drug-related adverse event, and changes of this magnitude in plasma oxalate level may impact long-term clinical outcomes, including those related to systemic oxalosis, which will be further evaluated in the extension period of the study. I thank you for your time, and I look forward to seeing everybody at the conference. Thank you.